Bismillahirrahmanirrahim. Quote of the day: anything is possible when you have the right people there to support you. Today, the topic of my presentation is cytomegalovirus under kind supervision of Professor Dr. Saira Afzal. Learning outline of my presentation is: first we introduce the case presentation, then epidemiological triad, level of prevention, then discuss about the congenital cytomegalovirus treatment, and at the end there is the recent updates. At the end of this presentation, participants would be able to describe the clinical features of cytomegalovirus, its epidemiological triad, and recent advances. And at the end, there is an MCQ session. First, we present the case about cytomegalovirus. The patient presented with acute mononucleosis and colitis caused by primary cytomegalovirus infection. This was characterized by the presence of atypical lymphocytes and hepatosplenomegaly, elevation of transaminase level, serological positive anti-cytomegalovirus, IgM antibodies, and cytomegalovirus antigenemia. Additionally, cytomegalovirus positive cells were histologically detected in clonic biopsy specimen. The patient's symptoms and clinical parameters improved by the initiation of intravenous Cyclover. It was concluded that even if patients with ulcerative colitis are not treated with steroids or immunosuppressant, there is a significant attention should be paid to acute cytomegalovirus infection in the context of severe or persistent chronic inflammation. Now discuss the cytomegalovirus. Cytomegalovirus infection is a common herpes virus infection with a wide range of symptoms from no symptom to fever and fatigue to severe symptoms involving the eyes, brain, or other internal organ. Cytomegalovirus, also known as heterophile negative mononucleosis. Herpes virus. There are almost 9 types of herpes virus, and there are different categories: herpes simplex virus 1 and 2, varicella zoster virus, Epstein-Barr virus, and the human cytomegalovirus virus is in the human herpes virus number 5. There is also human herpes 6A and 6B, human herpes 7 and 8 virus are also present. First isolated in 1956 from 2 dying infants from salivary glands and kidney with demonstration of inclusion bodies. It is also known as salivary gland virus. 1960, Weller et al. Proposed the name cytomegalovirus, and it is first isolated from renal transplant patient in 1965. What is the problem statement regarding the cytomegalovirus? In the United States, nearly 1/3 children are already affected with cytomegalovirus by age 5. Over half of adults have been infected with cytomegalovirus by age 40. Once cytomegalovirus is in a person's body, it stays there for a life and can reactivate. A person can also be reinfected with a different strain of the virus. Most people with cytomegalovirus infection have no symptom and are not aware that they have been infected. Beta herpes virus type 5 is responsible for cytomegalovirus infection. This family is largest in herpes virus, and there is a double stranded DNA enveloped virus, nucleocapsid 105 nanometer in diameter and 162 capsomer. And the hosts that are responsible for this disease. Almost cytomegalovirus infect people of all ages. Over half of adults have been infected with cytomegalovirus by age 40. There are equal susceptibility of getting infection in both gender, and there is no as such lifelong immunity. And in pregnancy, the virus is transmitted from mother to infant. And the main source of infection is saliva, urine, semen, blood, and the breast milk, almost all body secretions. The disease is transmitted via saliva, sexual contact, placental transfer, breastfeeding, blood transfusion, solid organ transplantation, and hematopoietic stem cell transplantation. 4 to 8 weeks, almost the incubation period of cytomegalovirus infection. And the clinical features, the patient present with these type of clinical features like fever, sore throat, fatigue, swollen glands. Occasionally cytomegalovirus can cause mononucleosis or hepatitis. People with weakened immune system who get cytomegalovirus can have more serious symptoms affecting the eyes, lungs, liver, esophagus, stomach, and intestine. Now we present the case of congenital cytomegalovirus. A 4-month-old female patient presented with complaint of vomiting, diarrhea, and body contraction. It was reported that the girl had been vomiting whenever she had eaten 3 to 4 times per day and having watery diarrhea 2 to 3 times per day since the previous week. Moreover, for the last 3 days, she had experienced a few seconds of contraction in her arms 3 to 4 times per day. The patient parents were found to have first degree consanguinity marriage, and the mother has a cesarean delivery. The patient had microcephaly with long eyelashes and upturned nose, highly arched palate, retrognathia, distinctive ears, and a short neck. She had medial deviation of the second finger, agenesis of the middle finger, and syndactyly of the fourth and fifth finger of the right foot. Moreover, she had irregular foot lines. Bilateral chorioretinitis was determined at the ophthalmological examination. The patient had impaired neuromotor development and had no control of her head and neck. All hepatitis markers are negative. Toxoplasmosis, Epstein-Barr virus, herpes simplex virus type 1 and 2, rubella, parvovirus beta 19, and HIV serologies were all negative. Serum cytomegalovirus IgM was positive in the neonate, IgG was positive, and urine cytomegalovirus DNA PCR was 3,303 million copies ml. The mother serum cytomegalovirus IgM was negative and the mother IgG was positive. So this is the case of congenital cytomegalovirus. Now we discuss the congenital cytomegalovirus. It is defined as the isolation of cytomegalovirus from the saliva or urine within 3 weeks of birth. Commonest congenital viral infection infects about 0.3 to 1% of all live birth. The second most common cause of mental handicap after Down syndrome and is responsible for more cases of congenital damage than rubella. This is the picture of a female girl baby with the infection of cytomegalovirus. Congenital cytomegalovirus infection. Most newborns with congenital cytomegalovirus are asymptomatic, but as many as 15% will develop progressive hearing loss. Approximately 10% of congenital infected newborns will have symptoms at birth. And the main sign and symptom of the congenital cytomegalovirus infected babies are hepatosplenomegaly, chorioretinitis, fatigue, purpura, jaundice, small size for gestational age, and microcephaly. Treatment for neonate with symptomatic infection treated with gencyclovir may protect against hearing loss and a developmental impairment. This is one of the study in which they observe the sign and symptom of the babies which are born with a cytomegalovirus. Only children of mothers with primary infection during pregnancy had symptomatic congenital cytomegalovirus, and the most common clinical findings in a newborn with symptomatic cytomegalovirus disease were jaundice, petechiae, and a hepatosplenomegaly. Cytomegalovirus infection, the main source is breast milk, immune complexes in the toddlers. There is a urine and saliva and sex and semen and cervical secretion are a common source of infection. The infection may be primary or a recurrent infection. In a primary, there is a fetal transmission, and in the fetus, there are 20 to 40% are symptomatic, and maybe it is asymptomatic. And in the symptomatic, there are intrauterine growth retardation, retinitis, microcephaly, jaundice, and hepatosplenomegaly. And from these symptomatic patients, most have a permanent damage like mental retardation, deafness, and blindness, and 20% almost having a death. And the late sequelae are the deafness and the learning deficiencies in the children of congenital cytomegalovirus infection. The, the disease having a silent global burden of a congenital cytomegalovirus, and the children who are suffering from a congenital cytomegalovirus have non-genetic childhood hearing loss and a neurodevelopmental delay. Successful implementation of strategies to prevent or reduce the burden of congenital cytomegalovirus infection will require highlight the global awareness among clinicians and a general population. In this review, we highlight the global epidemiology of congenital cytomegalovirus and the implication of a growing knowledge in areas of prevention, diagnosis, prognosis, and a management for both in the low prevalence and the high zero prevalence setting. There are many complications of cytomegalovirus like retinitis, colitis, esophagitis, hepatitis, encephalitis, and pneumonia. Now comes the level of prevention. In our primary prevention, we having a health promotion and a specific protection. And in the health education, wash your hands, avoid contact with tears and saliva when you kiss a child, avoid sharing food or drinking out of the same glass. Be careful with disposable items, clean toys and countertops, and practice safe sex because cytomegalovirus is preventable with these type of awareness. And there is a no licensed vaccine is available. There is a candidate live attenuated vaccine known as the Ton strain, but there are concern about administering a live vaccine which could become latent and reactivates. Prevention of cytomegalovirus disease in transplant recipient is a very complicated subject and varies from center to center. It may include the following measures. Screening and matching. Screening and matching the cytomegalovirus status of the donor and recipient. Use of cytomegalovirus negative blood for transfusion. Administration of cytomegalovirus immunoglobulins to a seronegative recipient prior to a transplant, and give antiviral agents such as acyclovir and gencyclovir prophylactically to a patient of transplant. And in the secondary prevention, we protect the disease with the help of early diagnosis and a prompt treatment. There are different tests which are available for the diagnosis of cytomegalovirus, like a quantitative cytomegalovirus DNA by a PCR diagnosis and monitor response. Qualitative cytomegalovirus DNA detection by PCR. It is extremely sensitive test and a tissue culture. Serum cytomegalovirus IgM and IgG antibodies. This test is good for screening. And in the histopathology, there is a delayed diagnosis and inadequate specimen collection. There are a difference between Epstein-Barr virus identification and cytomegalovirus. Epstein-Barr virus is a heterophile positive and cytomegalovirus is a heterophile negative. A growing number of pathogens have been reported to cause heterophile negative mononucleosis like illness, including cytomegalovirus, human herpes 6 virus, human immunodeficiency virus, adenovirus, herpes simplex virus, streptococcus pyogenes, and toxoplasma gondii. And the treatment of cytomegalovirus, treat with full dose of IV gencyclovar or oral. Vilganciclovir monitor cytomegalovirus viral load or antigenemia once weekly while on therapy. Generally continue treatment until undetectable. May consider a 1 to 3 month course of secondary prophylaxis after completion of treatment. How we deal with the cytomegalovirus infection in the transplant recipient. Cytomegalovirus infection is multifaceted phenomena with variety of direct and indirect effects in organ transplant recipient. Cytomegalovirus can disseminate to various organs and can cause death. Symptoms in a transplant patient, there is a fever, arthralgia, pneumonia, GI ulcer, hepatitis, and a multi-organ disease. Preventive strategies to minimize the clinical burden of cytomegalovirus in a transplant patient. To improve patient outcome, an interdisciplinary approach involving physician, pharmacist, microbiologist, nurses, and allied healthcare provider is needed to contribute at all stages of a patient care. This actively reviews the latest clinical evidence on the diagnosis, monitoring, and prevention of cytomegalovirus infection and disease, and will highlight the latest advances in diagnosis and antiviral development that can be used to improve long-term patient outcome. Now it's time for the recent updates. Cytomegalovirus is the most common infection causing of birth defect in the United States. About 1 out of every 200 babies is born with congenital cytomegalovirus infection. Of these babies, around 1 in 5 will have long-term health problems such as hearing loss, developmental and motor delay, vision loss, microcephaly, or seizures. CDC aimed to reduce the burden of congenital cytomegalovirus, work closely with national experts to conduct research and increase awareness of cytomegalovirus among the public and healthcare providers, evaluating the various laboratory tests for newborn screening for cytomegalovirus, determining the most effective screening approaches to identify babies with congenital cytomegalovirus, characterize the impact of the disease in various populations, and assessing the long-term outcomes of children with congenital cytomegalovirus. And with the help of education, updating our cytomegalovirus website regularly to include the latest information about congenital cytomegalovirus infection, developing and disseminating cytomegalovirus resources, promoting National Cytomegalovirus Awareness Month in June, and working with a partner to ensure our message about congenital cytomegalovirus reach healthcare providers, pregnant women, and a parent of a children born with congenital cytomegalovirus infection. Now it's time for the MCQs. A 78-year-old man with end-stage renal disease, diabetes mellitus, and microscopic polyangiitis, for which he was taking glucocorticoids, presented to clinic with complaint of fever, painful glossitis, and a taste abnormalities that has persisted for 1 month. The most likely diagnosis is cytomegalovirus infection, herpes simplex virus infection, Behçet disease, and syphilitic chancre.
A.
Cytomegalovirus is the right option. Organ transplantation is one of the complicated procedure. The risk of infection is highly reported in these patients. The most common viral infection after solid organ transplant between 1 to 4 months of surgery is cytomegalovirus, herpes, rubella, or HIV.
A.
A is the right answer. A male baby born at 39 weeks of gestation with petechial rash, low birth weight, hepatosplenomegaly, and microcephaly. This is thought that baby might be infected during pregnancy. Select the condition which likely caused this clinical presentation: rubella, toxoplasma gondii, group B, streptococcus, or cytomegalovirus infection.
B.
D is the right answer, cytomegalovirus infection. Which body secretion are most common in the mode of transmission of cytomegalovirus infection? Saliva, semen, urine, or blood?
B,
A. Saliva is the right answer. The prevalence of congenital cytomegalovirus infection is increasing in developing countries because of lack of awareness. Which symptom of congenital cytomegalovirus is highly reported? Jaundice, hepatosplenomegaly, chorioretinitis, microcephaly.
D,
A. Jaundice is the right option. Which of the following does not establish diagnosis of congenital cytomegalovirus infection in neonate? Urine culture for cytomegalovirus, IgG cytomegalovirus antibodies in blood, intranuclear inclusion bodies in hepatocyte, or cytomegalovirus viral DNA in blood by PCR.
A,
IgG cytomegalovirus antibodies in blood, because IgG cannot produce in the neonate, it is transferred from mother to baby. So the right answer is B. To confirm the diagnosis of congenital cytomegalovirus, one should request which laboratory test? Paired serology between mother and newborn in first week, IgG2 cytomegalovirus in newborn, blood for cytomegalovirus DNA in the first 3 months of life, urine or saliva for cytomegalovirus DNA in the first 3 weeks of life.
B,
D. Urine or saliva for cytomegalovirus DNA in the first 3 weeks of life. Which of the following statement is true? Babies with congenital cytomegalovirus usually have no symptom at birth. Babies with no clinical evidence of disease at birth have no risk of having hearing or neurological development. Two-thirds babies with congenital cytomegalovirus at birth having hearing or neurodevelopmental problem. Diagnosis of congenital cytomegalovirus is not possible up till 6 months of life due to maternal antibodies.
D,
C is the right answer. Two-thirds babies with congenital cytomegalovirus at birth having hearing or neurodevelopmental problem. Which is the most likely treatment of congenital cytomegalovirus infection? IV gencyclovir, oral gencyclovir, refer to audiologist, manage symptomatically.
A,
A is the right answer. IV gencyclovir. Congenital cytomegalovirus is second leading cause of neurodevelopmental delay after Down syndrome. In how many weeks isolation of cytomegalovirus from saliva and urine of infected newborn? Within 1 week, within 2 weeks, within 3 weeks, within 4 weeks.
C,
C, within 3 weeks is the right answer. This is the key of my MCQs, and thank you.
thank you so much, Dr.